This was the second case, and as Gary had brought up, one of the major kind of issues that you run into is, being able to get to your target lesion, successfully treat it. And with regards to upper extremities, avoiding any sort of morbidity of cut downs is certainly advantageous, as we all know. So this device has really became one of our workhorses for successfully treating upper extremity acute thromboembolic events as well too. Next slide. This was a case, again, we have a wonderful group of interventional cardiologists that we do a lot of collaboration with. They're very good at what they do. And when they do call, we knew that there was something going on. This was a woman in her 70s. She had all the alphabet soup as far as her past medical history, unfortunately presented with a STEMI and acute heart failure exacerbation. Next line. Ended up getting taken to cath lab, successfully underwent PCI, and then post-procedurally in CVICU ended up having a access-related complication that was attempted to be controlled through radial access and subsequent prolonged ballooning and different techniques. After that failed, there was an attempt at a Viabond stent delivery from the radial access that was unsuccessful. At that time period, she was pretty hemodynamically unstable, and this is where I got involved. Next slide, sorry. The Viabond stent, unfortunately, got stuck in the radial artery, and I knew at that time period the only way that I was going to be able to remove it was to actually open and excise the vessel in order to get rid of it. There is a ulnar signal per report, and prior to, of course, accessing for the intervention to control hemorrhage. And so basically the plan was just to remove it, and that was going to be the option. But upon removal and ligation, there is no flow appreciated in the hand. Next slide. You can see at that time period, there is already access in the superficial femoral artery, which was how in the long run the hemorrhage was controlled in the groin access down in cath lab prior. So I elected to shoot an angiogram and showed that there was indeed a thrombus within the brachial artery. Next line. So with their pressure requirements being what they were, in an attempt to really reduce the length of the operation, knowing the access was already available, I went ahead and gained access up through the aorta and left subclavian axillary, and delivered an 8 French sheath in that area, and was able to very easily cross this acute thrombus that was in this very vasoconstricted brachial artery. And I used the Pounce LP system. Next slide. And after 2 passes, the yellow area you can see there, this was after a single pass. The middle image on the screen here was after 2 passes, and you can see clearly here that the ulnar is then feeding all the way into the hand. So within 20 minutes of this additional complication with somebody that was hemodynamically, pretty questionable at that standpoint, after having undergone all the cardiac interventions, I was able to do 2 passes, remove the device, close the superficial femoral artery, and complete this operation with limb salvage, again, showing its utility.